This is Dr. Saad Usmani from Levine Cancer Institute in North Carolina, and I'm Jens Hillengass from Heidelberg University in Germany. And we are here at the Myeloma 2017 meeting, and we're discussing about our last session on imaging in multiple myeloma. And I think it was very nice that you summarized what is going on in imaging, because for decades we just used X-ray and we just saw a few lesions, and when we saw it, it was I think pretty much too late. And so what's your take of what we have discussed? What's the most important message?
I think we had a very important session, especially keeping in context, everything that we're talking about. We have a much better understanding of myeloma as a disease. We understand that myeloma is very heterogeneous in different parts of the bones or even in the solid organs. So from that standpoint, I think we had a fantastic session. We first started off with that biologic understanding. We had Leo Rache present some of the data about the nuances of, that there might be certain myelomas that do not pick up glucose. So whether, FDG is the right kind of label to use with PET-CT. Then, he did talk about the special heterogeneity in myeloma before you went into details about, all about what's a lesion. So, you can probably comment more on that.
Yeah, I mean, we've learned that there are some patients showing the diffuse infiltration, what we would expect from a hematological systemic disease. And we know, but on the other hand, that there are those focal osteolysis, which is common knowledge in myeloma treatment or in myeloma diagnostics. And we also see that in the more sophisticated techniques, where we can see that some patients have this diffuse infiltration, some have those focal lesions, some have mixed patterns, and some even have normal-looking bone marrow. And I also like very much the talk from Leo Rache from Little Rock, Arkansas, showing that if you put a needle in those focal lesions, you can see really that there are different cells in those focal lesions compared to the bone marrow. And we did actually the same in Heidelberg. We also have a prospective trial on that, and we found that there's not that big a difference. So, and the Arkansas group also found that some patients have a huge difference in the genomic landscape of those cells, and we found that there's not that much difference, and they also had some patients where they were rather similar. I think that's very interesting, and I think we can learn a lot about this. And someone asked during the session and during the discussion what is happening after therapy, because it was also a huge topic today in MRD. Should we do imaging and MRD from the bone marrow? Should we only do MRD of the bone marrow? What's your take? What would you say?
I think these, both these modalities are complementary. We have to recognize that, until we get liquid biopsies or stage of liquid biopsies, we're still relying on that pelvic bone biopsy to look at MRD. But we also know, we discussed the IFM 2009 data. I showed some slides around that even with MRD negativity, doesn't matter if it's 10 to the -5 or -6, you do have PET positivity. So that's where, the discussion becomes very relevant. It's important to understand what's really happening in that focal lesion disease. Eventually, that's the disease that will come back. It survived after duress of therapy. And so when we're thinking about prognosticating and following response in active disease, that's important. I was also very interested in the discussion we had, between the skeletal survey and the role of the whole body low-dose CT. Some people were interested, should we be switching over to that? And since that's your study, I just wanted to get your impression on that.
Yeah, thank you. We have had this multi-center approach where we combined CT or use CTs and conventional X-ray survey from different centers from all over the world, which is also very interesting to see who is using what and how effective is it. And we found that about 25% are only positive in CT, so we would miss them if we only used conventional X-ray. I think most of the people in the audience also agreed that CT is a new standard imaging technique for bone disease especially. But we also discussed that it's not only bone disease, but you can also see focal lesions before they destroy the bone. So again, another layer of interesting topic of research where we can see why are some lesions really leading to osteolysis, destroying bone, and others don't. So I think there's a lot to do still. And I liked also the last talk on the different traces. You already mentioned that FDG might not be the best one because some patients are negative even though they have focal lesions. And I think it's very interesting what the Würzburg group and presented by Martin Kortum, what they do, trying different traces, which is more specific for which patient. And so it's very interesting, a whole new field of research for myeloma, which was not there. I mean, we were very happy with FDG-PET, but now they have shown there are more sensitive traces, more specific traces. And are you using FDG-PET, I guess?
Yes, right now we're doing FDG-PET, but I'm really interested in exploring the different radio labels, and there are certain monoclonal antibody-based radio labels that are making their way. In mouse models, we just had a daratumumab-based mouse model that was recently published in literature. So there are things of that nature making their way that are making imaging very exciting.
Yeah, so I think that's a good summary and a good conclusion of our experience in this last session. I think imaging is getting more and more interesting in myeloma. It's not just X-ray, as we said, and those focal lesions we find are very interesting too, especially when you look for the spatial heterogeneity, but also as residual lesions after therapy. And I think there's a lot to do, and there's a whole new field of research, and I think it's very interesting to look what will be coming in the next years. Thank you very much, Saad.
Thank you.